Without much ado, I'll just call upon the first speaker for this session, and Dr. Rajesh Joshi, to speak about trypan blue, which concentration is suitable. And the timer to be set for 5 minutes. The organizers make note, the timer to be set for 5 minutes.
Respected judges and my dear friends.
इधर नहीं आ रहा है, एक मिनट. Timer नहीं आ रहा है.
Yeah, it is there.
No, here we can't see. Yeah, it's there. Up.
I will be presenting this paper on trypan blue, which concentration is suitable. Nothing to disclose. As you all know, continuous curvilinear capsulorhexis is an integral part of cataract surgery, and the visualization of red reflex is essential for proper CCC. In the absence of red reflex, the initiation and the completion of the CCC is challenging. In mature cataract, the red reflex from the retina is absent. Therefore, the staining of the anterior capsule with the dye is recommended. The normal concentration of commercially available trypan blue dye in market is 0.06%, and it is available in 2 ml vial. The problem reported in the literature due to this normal concentration of trypan blue dye is the toxic anterior segment syndrome and permanent discoloration of the hydrogel intraocular lenses and inadvertent blue staining of the posterior capsule with its use. Therefore, the aim of the present study was to evaluate the exactly which concentration of the trypan blue dye is suitable for the successful staining of the anterior capsule in mature cataract while decreasing the chances of its side effect. It was prospective, observational, comparative and interventional study done in the Tertiary Eye Care Center Institute in the Central India from December 22 to February 23. Ethical approval was obtained from the ethical committee. The sample size was in each group was 41 eyes with the confidence interval of 80%, and in group 1 the staining was done with normal concentration of the dye. In group 2 it was diluted in 1:2 proportion. In group 3 it was 1:4, and group 4 it was 1:5 dilution. The inclusion criteria was mature senile cataract. Exclusion was immature cataract, eyes with small pupil, complicated cataract, traumatic cataract, subluxated, one-eyed patients, and eyes with visible red glow, developmental and congenital cataract. Routine preoperative assessment was done in each and every patient. Single surgeon performed all cataract surgeries under topical anesthesia. This shows the staining of the capsule with 0.06%. The video is not working, in fact. Let it be. It was downloaded, in fact. Anyway, yeah. It was stained with all the concentration, and as you decrease the concentration, the staining of the anterior capsule was reduced. The assessment of the staining characteristic in each group was performed with in the form of visibility of the anterior capsule staining, initiation of the anterior capsular flap, CCC completion, surgical time for CCC, and the CCC extension. Visibility of the anterior capsule during phacoemulsification and the placement of IOL in the capsular bag was done. Criteria studied for the scoring of the various staining characteristic was ease of the staining, initiation of the anterior capsular flap, visibility of the staining, and the ability to perform anterior capsule opening. Ease of the staining was done from +1 to +3 with the difficult staining +1 and easy one with +3. The mean age of the participant was 67.42 with 98 females and 66 males. The type of the cataract was hypermature Morganian cataract. In 50 eyes, 60 eyes had hypermature sclerotic cataract and 44 eyes had intumescent cataract. This shows the staining characteristic in each group. With decrease in the concentration of the dye, there was reduction in the staining of the anterior capsule and the initiation
Please
of the
go
flap,
to the conclusion.
But it was possible to stain the anterior capsule. This was the mean CCC time. It wasn't significant. The CCC extension was done in 2 cases with 0.03% and 0.015%, and 1 case in 0.06 and 0.075%. None of the patient had anterior capsular catch, none had PCR, and no patient had elevated IOP on first post-op day. This shows the histopathological photographs in both the stained groups, and there wasn't any difference in the staining characteristics. We could find out two studies in this group, one by Melis group and the other one was Marbeck. We used less concentration than mentioned in the above studies and found out that if the eye is used if the less concentration of the dye is used, 0.025%, that is 0.075, still the CCC is possible and easily can be done without any complication. The key silent features of the study was most of the other studies have stained anterior capsule under OVD. We stained anterior capsule under air, that too using single syringe filled with air. The single stage technique requires very less time as compared to OVD, yet the surgical time for performing CCC was significant. The strength of the study was prospective design, sufficient sample size, and intraoperative factors such as time for CCC completion, visibility of the margin, and complication were studied. This was the limitation of the study. And so the conclusion of the study was with low concentration of the dye, it was possible to stain the anterior capsule, which is economical for high volume cataract surgeries. And this is an implication in developing countries and potentially decrease the cost of the surgery. Thank you.
So what do you recommend your study? Just what's the recommendation from your study?
Recommendation is that we can use less concentration. As you can see, if you have a single case like, and if you use 0.06%, which is available in 2 ml vial, the rest of the volume of the vial is wasted. If the manufacturer can reduce the concentration as well as amount of the dye in the vial itself, a lot of money can be saved. It would be economical for the surgeon point of view as well as for the industrial point of view.
Have you got any observation on the elasticity of the lens capsule on different concentrations?
Not yet. That was beyond the scope of the study.
Okay.
Yeah.
We call upon the next.
Thank you.
Next speaker, Dr. Anu B. John, to tell on recovery of corneal sensation following phaco versus manual small incision cataract surgeries.
A very good evening to all present here. Thank you AIOS for giving me the opportunity to present my research on recovery of corneal sensation following phaco versus manual small incision cataract surgery. Cornea is a very abundantly innervated structure in the body, and normal corneal sensitivity is very important, which when hampered causes a lot of problem to the patient. Cataract is the most common cause of visual impairment and unfortunately can be resolved only by cataract surgery. Phacoemulsification and SICS are the most commonly performed surgeries at present. Corneal sensations can be assessed either qualitatively using a wisp of cotton or quantitatively using a Cochet-Bonnet aesthesiometer. The aim of a study was to compare the differences in the pattern of recovery of corneal sensation in phacosurgery and SICS using a Cochet-Bonnet aesthesiometer over a 6-month follow-up period, and to quantify these changes in corneal sensation in the immediate versus late post-op follow-up. Ours was a prospective observational study. First, 100 patients undergoing either of the cataract surgeries were enrolled and were grouped as phaco for the group 1 and SICS group 2. Any patient who had a pre-existing ocular disorder that could cause a decreased corneal sensation was excluded from the study. CBA was used for the study. Patient was seated at the slit lamp and was advised to look at a straight target. Filament extended to full length of 60 mm. The filament was gently touched on the surface of the cornea at the desired point perpendicular to the surface of the cornea. Filament was then retracted in 5 mm steps each time for a negative response, which is absence of a blink or a subjectively patient telling that he did not feel touch. Filament was sterilized after use and according to the company protocol, and 15 minutes minimally was given for it to be used for the next patient. Measurements were done both preoperatively and postoperatively for 4 visits. Data was entered using epidata and analyzed using SPSS 25. P-value less than 0.05 was taken as significant. 200 eyes in 200 patients were observed. Laterality, sex, and age did not show any statistical difference. The mean corneal sensitivity reduction was seen in postoperative visit 1, which gradually increased and recovered by the postoperative 4th visit. This shows the similar finding with the phaco group achieving recovery faster than the SICS group. This is another graph showing, another table showing the similar change. However, we have noticed that in our institute, since we do a superior incision in cataract surgery, the superior quadrants were affected and the corneal sensation gradually recovered in those quadrants during the follow-up. Cataract surgery is one of the oldest forms of surgery. However, now we do have highly refined surgical techniques, but the patients also have increasing demands and expectations. We have done a 6-month follow-up. The previous studies that were done did not have a prolonged follow-up, and also the trend of recovery was not very conclusive. So the corneal sensations do show a reduction in both the groups. However, the phaco group reached a baseline by 6 months, and SICS group did show a recovery by 6 months. The phaco group again showed a reduction in the corneal sensitivity in the superior quadrants from 10 to 12 o'clock, and SICS group showed from 10:30 to 1:30 clock position. An interesting finding that we had in our study was the paracentesis is also made in a similar fashion at 3 o'clock and 9 o'clock position. There was a drop in the mean corneal sensitivity at 9 o'clock position, which possibly can be explained because we have the right-handed surgeons, and the 9 o'clock side port may be the preferred use of for instrumentation during the surgical procedure. The larger reduction in corneal sensitivity is seen in the SICS group, probably due to the more damage of the corneal nerves than the phaco group, and phaco group also showed a quick recovery of the corneal function post-operatively. There was a linear recovering trend of corneal sensation. The phaco group, again, as I mentioned earlier, showed a faster recovery, reaching the baseline value somewhere between 3rd and 4th post-operative visits. Phaco cataract surgery inflicts lesser damage on the corneal nerves as compared to SICS. It is very important for us as clinicians to be aware of these changes and counsel our patients undergoing surgery to address their expectation, leading to a better post-operative experience for the patient. After all, a happy patient keeps a happy doctor. Thank you.
Does the position of incision makes a difference? Is the
Sorry.
corneal or limbal or some?
Sorry, sir?
If the phaco incision is corneal, phaco incision is limbal, or maybe little conjunctival also, does it make difference?
So we enrolled all the patients who were undergoing corneal incision phaco, sir.
Clear
So-
corneal.
Yeah, clear corneal incision, sir.
But your SICS were not clear corneal.
So yeah, that was a sclerocorneal tunnel that was created and then entered into the anterior chamber.
Where was the
in the
site
clear corneal, did you go for anterior limbal or mid limbal or posterior limbal?
It was anterior into the cornea, sir.
Into the cornea.
Yes, sir.
And that was sclerocorneal.
That was a sclerocorneal, sir.
Was there any consistency maintained with regard to the SACS length of the surgery
So in our institute, we do a superior incision with 5 mm incision
for all the patients?
for most of the patients. So if we expect a larger nucleus or a hard cataract, then we may prefer a 5.5 mm. But yes, the arc length does make a difference.
So even phacos are also done in the superior quadrant.
Yes, sir. We had maintained that sort of uniformity. Thank you, sir.
Thank you.
Yes, sir. We call upon the next speaker, Dr. Hemant Ramachandran, to speak on clinical parameters versus inflammatory markers, best indicator of dry eye disease post cataract surgery. He's not there. We then have Dr. Aparna Rajgopalan to speak on refractive outcomes in high myopes, comparing Barrett 2, SRK2 and Wang's-Cox adjusted SRK-T.
Good evening, everyone. I'll be presenting refractory outcomes in high myopes comparing Barrett Universal to SRK-T and Wang's-Cox adjusted SRK-T. Cataract surgery in high myopes can be challenging because of the postoperative refractive surprises and patient dissatisfaction. The older generation formulas can lead to refractive surprises when used in high myopes because of the errors in calculating axial length, ELP, and IOL constants. The newer generation formulas like Barrett Universal 2 can give satisfactory result after cataract surgery in these patients, but it could be used only in advanced machines like IOL Master. So, our aim is to study the refractive outcomes in high myopia patients with axial length greater than 27 mm undergoing phacoemulsification and in-the-back IOL implantation using Barrett, comparing Barrett, SRK-T and Wang's-Cox adjusted SRK-T. So, ours was a single center retrospective study. EMR of the patients with axial length more than 27 mm and with a minimum postoperative follow-up of 3 months was evaluated. We evaluated the demographic data, pre-op BCVA, spherical equivalent, anterior segment, posterior segment findings, and post-op refraction. A-scan biometry was done using IOL Master 700. In case of media opacity, axial length was calculated using immersion biometry. IOL power calculated with Barrett Universal 2 was implanted in all eyes, and then biometry was repeated using SRKT with actual axial length and Bangkok adjusted axial length to know the residual refraction. The optimized axial length equal to 0.8453 into measured axial length plus 4.0773. We excluded those patients who underwent SICS, post-refractive procedures like LASIK, secondary IOL implantation, those who are left phakic, those who had ocular conditions affecting visual acuity other than high myopia, and those who had intraoperative complications. Coming to the results, the mean age was 53.2 plus or minus 12.2 years. We had 100 eyes of 80 patients, that is 20 patients underwent surgery bilaterally. Of these, 41 were males and 39 were females. The mean axial length was 29.37 plus or minus 1.89 mm. The mean ACD was 3.47 plus or minus 0.39. 83 eyes was implanted with plus powered IOLs and 17 with minus powered IOLs. We compared the variables in accordance with the axial length, that is into two groups, less than 30 mm axial length and more than 30 mm axial length. And we found that in more than 30 mm axial length, there were more males, that is about 40%, and the mean age was 48 in greater than 30 mm axial length, and it was 55.8 in less than 30 mm axial length. But there was no much significant difference between K reading and AC depth. The overall means preoperative spherical equivalent was minus 12 plus or minus 5.5. The mean preoperative best corrected visual acuity was logmar 0.7, and postoperative BCVA was logmar 0.2, which shows a good postoperative outcome following cataract surgery in these high myopes, and which can give which can lead to good refractive outcomes. And the mean IOL power was 6.2 plus or minus 3.6 in axial length less than 30 mm and minus 0.4 plus or minus 2.6 in more than 30 mm group. This table shows the residual refraction plus powered IOLs. Here we can see the Barrett and SRKT with Bangkok adjusted axial length showed similar results, but with normal axial length, SRKT is giving hyperopic surprises. In minus powered IOLs, this hyperopic surprises was exaggerated with normal axial length while using SRKT, but with Barrett and with SRKT using Bangkok adjusted axial length, it gives similar results. The mean residual refraction with Barrett was minus 0.25. It was 0.65 with SRKT using normal axial length. It was minus 0.16 using SRKT with Bangkok adjusted axial length, which is similar to the Barrett Universal 2. Some studies stating similar results. A study by Sang et al. Showed that SRKT with axial length adjustment can give similar results to the newer generation formula. And another study by Fouch-Rabi et al. Showed that Bangkok adjustment in the axial length can give similar results to Barrett Universal 2. So concluding, SRKT with Bangkok adjusted axial length can provide satisfactory results in high myopia as compared to Barrett Universal 2. Since newer generation formula can be used only in advanced machines, those peripheral centers where these expensive machines are not available, SRKT formula with Bangkok adjustment can be used as an alternative in these cases. In our case, only 15 eyes had UCVA of logma 0 and 35 improved to logma 0 with correction. So rest 50 didn't improve to logma 0, so we couldn't use the postoperative refraction for comparing the performance of these two formulas. So we did a logistic regression analysis to find out the factors which affect the postoperative vision, and we found that axial length, CNVM, and myopic macular degeneration with posterior staphyloma was associated with postoperative low vision, and it was found to be statistically significant. These are my references. Thank you.
You also correlate with any of these newer machines?
Sorry, sir?
Newer machines, IOL machines, did you correlate with any of this correction?
Yes, sir. We did the residual refraction using IOL master only. Like we did the residual
What
refraction.
version was it used? IOL master?
700.
700.
Yes.
Okay. So was it?
We actually repeated the biometry with SRKT with the normal axial length and the Bangkok adjusted axial length using IOL master 700. Yes.
Okay.
Thank you, sir.
Here. So we move on to the next talk by Dr. Angita Ravi.
She'll be speaking on the aborted suprachoroidal hemorrhage presenting as pseudomelanoma. Do not forget the psyched output.
Good afternoon, everyone. I'll be talking about aborted suprachoroidal hemorrhage presenting as pseudomelanoma. Don't get psyched out. So suprachoroidal hemorrhage is a rare but sight-threatening complication in intraocular surgeries. It can present as a choroidal mass after surgery and cause a diagnostic dilemma. So I'll be talking about two localized suprachoroidal hemorrhage cases which presented as a choroidal mass one day after cataract surgery. So first patient was a 41-year-old female. She was underwent left eye phacoemulsification elsewhere. So intraoperatively severe positive pressure was noted and IOL implantation was deferred. History-wise examination was nothing was relevant, and on ocular examination on post-operative day 1, right eye had 6/9, which was improved to 6/6, and NS2 cataract was there. In left eye, 1/60 uncorrected visual acuity, which was improved to 6/12 with +10 diopter, and that eye was aphakic. So on fundus evaluation, there was a localized dome-shaped elevated choroidal mass lesion inferiorly was found. On B scan, there was a low to medium internal reflectivity with OCT scan showing lumpy bumpy appearance along the margins. FFA was showing early hyperfluorescence with late leakage, and ICG was showing early hypersensitivity with the late leakage. Keeping a differential diagnosis of choroidal melanoma, choroidal granuloma, and choroidal hemangioma, the patient was referred to ocular oncologist. So on post-operative day 15, patient came to ocular oncology department in our hospital. So on fundus evaluation, there were few choroidal folds were seen, but no mass lesion was found. So we came to a diagnosis of arrested suprachoroidal hemorrhage, and she was treated conservatively and planned for secondary IOL, but unfortunately the patient lost to follow-up. After 6 months, she came back, no mass was seen. Second case, 62-year-old female. She came with complaints of defective vision in both eyes for 6 months. On ocular examination, both eyes were having 6/12 vision, which was improved to 6/6 partial. Right eye was showing nuclear sclerosis grade 2, and left eye was showing nuclear sclerosis grade 2 with the PSCC. She was underwent left eye phacoemulsification with the PCIOL. Surgery went uneventful. Next day, fundus evaluation, there was an elevated mass lesion superotemporal to the fovea with choroidal folds. So she was treated conservatively. After 2 weeks, the mass was disappeared, just like in OCT. So to summarize, in both the cases, there were choroidal fundus mass lesion in post-operative day 1, but with conservative treatment, after 2 weeks, both the masses were disappeared. So these are the cases of aborted expulsive hemorrhage. Spontaneous localized suprachoroidal hemorrhage is a rare differential diagnosis of a choroidal mass lesion. It accounts for 2% of pseudomelanomas. With multimodal imaging, we can differentiate various choroidal mass lesions. We can just go through the differences of choroidal mass lesion. These are suprachoroidal hemorrhage, choroidal melanoma, choroidal granuloma, hemangioma, and posterior scleritis, among which posterior scleritis will be painful. When we look into B-scan internal reflectivity, melanoma, SCH, and posterior scleritis will be having low internal reflectivity, and hemangioma will be having high internal reflectivity. So a typical localized SCH will be having an appearance of dome-shaped choroidal mass lesion, and B-scan will be having echogenic or low internal reflectivity. FFA ICG will be having no remarkable features, and OCT will be showing hyperreflective lesion in outer choroid with elevated retinochoroidal complex. The pathogenesis of SCH, acute hypertony or sudden fluctuation in intraocular pressure can lead to rupture of posterior ciliary arteries or vortex veins. So in our first case, severe positive pressure was noted during surgery, so it's a most likely a case of intraoperative suprachoroidal hemorrhage. The second case is a delayed suprachoroidal hemorrhage. These are various risk factors for suprachoroidal hemorrhages, among which our first patient had hard nuclear cataract as a risk factor, and second patient had none of these risk factors. So post-operative management for localized suprachoroidal hemorrhages and non-appositional suprachoroidal hemorrhages, we can just observe in these patients because spontaneous resolution can happen in weeks to months in these patients. So topical or oral steroids, which will help in control inflammation and promote clot liquefaction. Anti-glaucoma medications for high OAP cases we can consider. Topical cycloplegics and oral analgesia to relieve secondary pain. To conclude, localized suprachoroidal hemorrhage is a rare but potentially sight-threatening complication of intraocular surgeries. Careful postoperative fundus evaluation is important to identify SCH, which enables timely intervention or conservative management. Multimodal imaging helps to differentiate SCH from other choroidal mass lesions. Thank you.
In both the cases, were there any other risk factors?
No, sir,
The globe hypotony or any other? One was globe was hard.
yeah.
In the second one, what was the
No,
nature
sir,
of the?
it was uneventful. The surgery was uneventful.
There is no other associated systemic.
Nothing was there, sir.
Nothing was there. What is attributable for the the arrested suprachoroidal hemorrhage?
Sorry, sir.
What was the reason
recent. So in first case, that hard nuclear cataract can itself cause this thing. And second,
So meaning to say is the duration of the surgery also has a bearing on the, because both are phaco?
both are phaco, sir.
There, the patient was not hypertensive, not atherosclerotic,
Yes, sir.
no fundus evidence of atherosclerosis.
No, sir, nothing was there. Systemic
Okay.
examination, nothing was there.
In the second case, why did the surgery was done? It was the base corrected vision was 6/6 and NS2 only.
PSCC was
PSC,
there.
the
MST
patient
PSC.
complained. Okay.
Yes.
It was done on a topical or
First case was topical. Yeah, both the cases were topical only, sir, for phaco.
Okay.
Thank you, sir.
We now move on to the next speaker. Presenting author is Dr. Tania. She'll be speaking on detection of posterior capsule integrity in posterior polar cataract using Swept-Source OCT.
Good evening, everyone. Our study is on detection of posterior capsule integrity in posterior polar cataract using Swept-Source OCT. No financial disclosure. Introduction. PPC have always been a challenge for cataract surgeons. Abnormal additions of posterior capsule to polar opacity or a pre-existing weakness of the posterior capsule, both of which predispose the eye to posterior capsule rupture. 20% of cases have a congenital defect of posterior capsule which have been reported. There are various methods which are used preoperatively to assess the integrity of posterior capsule, which include anterior segment OCT, 25 megahertz B-scan, modified OCT. But these are additional investigations which is time consuming and not universally available. IOL Master 700 is a Swept-Source OCT based optical biometer used for IOL power calculation. It can detect the posterior capsule as well as detect gross macular pathology. Purpose of our study is to identify eyes with PPC at high risk of posterior capsule rupture during preoperative biometry using Swept-Source OCT based IOL Master 700. It was done in Tertiary Eye Hospital, Tamil Nadu, prospective observational study from November 2022 to August 2023. 113 eyes of 106 patients were studied. Patients who were diagnosed with PPC who underwent biometry by IOL Master 700 followed by phacoemulsification were included. Eyes with prior intravitreal injection, shallow AC, ocular trauma, pre-existing corneal or retinal pathology, combined procedures, biometry other than IOL Master 700, age less than 18 years were excluded. Preoperative evaluation included visual acuity assessment, slit lamp biomicroscopy, IOP measurement, posterior segment examination. IOL Master 700 Swept-Source OCT images were taken in all cases. It was either grouped into intact posterior capsule or dehiscent posterior capsule. In case of intact posterior capsule, the capsular margin was traceable without any defect or discontinuity. In case of dehiscent posterior capsule, bumpy and irregular appearance with discontinuity was seen. All patients underwent clear corneal phacoemulsification. 5 anterior segment surgeons performed surgery. Hydrodelineation was performed, followed by direct chop technique. In case of no PCR, IOL was placed in the bag, like in this picture. In case of PCR, IOL was placed in the sulcus. Statistical analysis was done using Fisher's exact test. Sensitivity was defined as eyes with PC dehiscence on imaging, in which PCR was noted intraoperatively. Specificity as eyes with intact PC on imaging having no PCR intraoperatively. Positive predictive value as probability of eyes with PCR having dehiscent PC on imaging. Negative predictive value as eyes with no PCR having intact PC on imaging. 113 eyes of 106 patients met eligibility criteria. The mean age was 52.52. The range was from 19 to 75 years. Majority were male, majority belonged to right eye. Results. On IOL Master 700, the PC was found to be intact in 99 eyes. Out of these 99 eyes, 95 eyes had intact PC intraoperatively. 4 eyes had PCR. IOL Master 700 showed dehiscent PC in 14 eyes. Out of these 14 eyes, 13 eyes had PCR. 1 eye had intact PC intraoperatively. The sensitivity was 92.9%, specificity 96%, positive predictive value 76.5%, negative predictive value 99%. Intraoperatively, PC was found to be intact in 96 eyes. PCR occurred in 17 eyes. The rate of PCR was same during cortex aspiration and emulsification, both of it is same. The incidence of PCR has reduced from 36 to 6 to 7%, which is due to success of different surgical techniques. Newer modalities, as already discussed, have enabled better surgical planning and customized preoperative counseling of each case of PPC, resulting in favorable visual prognosis. Our study uses IOL 700 during preoperative biometry to detect high-risk PPC cases with PC dehiscence, which are at high risk of PCR. So IOL 700 accurately predicted intact PC in 95 eyes. 13 eyes out of 17 eyes with PCR were accurately predicted to have dehiscent PC. So first row image belongs to same patient. Patient had intact PC on imaging, and post-operatively, intraoperatively also the PC was found to be intact. Second row belongs to second patient, in which there was PC dehiscence on IOL 700. Patient had PCR intraoperatively. One case was identified to have PC dehiscence on imaging, but PC was found to be intact with PC plug intraoperatively. The same case had dense PC opacity more than 4 mm, making PC visualization difficult. PCO was seen post-operatively, suggesting surgeon may have carefully performed the surgery without disturbing the plug. Our study was compared with Pawan Kumar et al. And Chan et al., who used AIOC in PPC cases to see PC dehiscence. Most multicentric studies with large sample size comparing anterior segment OCT and IOL 700 in
Please
predicting
conclude.
PCR to confirm our finding. And the strength of our study, it's a prospective study. Limitation is that cataract surgery was performed by different surgeons. So interpersonal variability may have affected the PCR rates. These are my references. Thank you.
These observations did compel you to change the surgical procedure in both the groups?
Yes, sir. When on IOL 700, when we have a suspicion that there's a high chance of PC dehiscence, while after completing phacoemulsification, the surgeon could use a viscoelastic into the eye before taking out the phaco probe. This can prevent further vitreous loss or
That was
nucleus
the
loss.
only step you took because you know that there is already dehiscence. Was that only step as a precaution you have taken?
Also, the vitrectomy machine can be set.
Okay.
It can be kept ready when a PCR is anticipated.
About hydrodissection?
Hydrodelineation was performed in all cases.
Hydrodissection
Hydrodissection was avoided.
avoided. Bottle height and phaco parameters, did you change anything?
Sir, all PPC cases in our setup, it's done under low parameters. So,
Okay.
And one could use viscodissection in these cases.
hydrodelineation was performed, sir.
Hydrodissection is good, and viscodissection also makes a lot of things safer.
Just for academics, I am asking you, can you tell me the grades of PPC?
So there are 4 grades of PPC. Grade 3 and grade 4, there is high risk of PCR.
Was
In
it a
grade
sim-
4, there is absence of PC. In grade 3, there is high dehiscence of PC. It is present but highly dehiscent.
Was it a single surgeon who is operating, or
No, it was performed by 5 different anterior segment surgeons.
that was a limitation? Okay. Next we
Thank
call
you.
upon Next we call upon Dr. Shayal Vasavada to speak on visual outcomes following implantation of EDOF IOL in patients with macular degeneration.
Thank you very much. This study was funded in part by research grant support from Alcon Laboratories. So the purpose was to evaluate visual outcomes following implantation of a non-diffractive extended vision IOL in patients with pre-existing early dry macular degeneration. It was a prospective interventional case series performed at Raghudipai Hospital, Ahmedabad and Jaipur. Study population was patients above 40 years of age undergoing phacoemulsification for non-traumatic cataracts, and all eyes underwent in the bag IOL implantation of the Vivity IOL in this case. patients with uncomplicated age-related cataracts and nuclear sclerosis ranging from grade 1 to 4 on the LOCS grading 3 system were included, with pre-existing stable early dry age-related macular degeneration, which was defined based on the AREDS2 study criteria. So early dry ARMD is defined as multiple small drusen's less than 67 microns or few intermediate drusen's 63 to 125 microns or pigmentary changes at the macula. So this definition includes clinical fundus photography as well as posterior segment OCT. Exclusion criteria were all patients with either wet ARMD, severe dry ARMD according to AREDS 3, large drusen's, or any other retinal or ocular pathology or comorbidities. The primary outcome was monoocular corrected distance visual acuity, that is CDVA logMAR, at 4 meters on the ETDRS chart. The secondary outcome measures were monoocular unaided distance visual acuity at 4 meters, monoocular uncorrected and distance corrected intermediate visual acuity, and similarly monoocular uncorrected and distance corrected near visual acuity at 40 centimeters. The age distribution, the average age was 68.5 with a standard deviation of 8.38 years. There was an equal distribution of males and females and almost equal distribution of right eye and left eye. And all eyes had an axial length, a normal axial length, no high myopes or no high hypermetropes were included. Average grade of nuclear sclerosis was 2. And 63% of the patients received a toric version of the VVT IOL, and the preoperative corrected distance visual acuity was 0.36 logMAR. Coming to the results, the distance visual acuity of 40 eyes of the 40 patients, the uncorrected distance visual acuity was 0.12 plus or minus 0.07 logMAR. So 0.12 is equivalent to about 69 parts, and the corrected distance visual acuity was 0.1 plus or minus 0.1. So the mean corrected distance visual acuity in Snellens was equivalent to 6 by 7.5. The uncorrected near visual outcomes, which at 66 centimeters, which are our secondary outcomes, was 0.25 plus or minus 0.9. Corrected was 0.1. Similarly, the uncorrected near visual acuity was 0.23 plus or minus 0.1, and the corrected was 0.1. And the average near add required was 0.86 diopters for intermediate and 1.3 diopters plus or minus 0.18 for near was required. The most important part, comparing the contrast sensitivity with and without glare at different cycles per distance at 3, 6, 12 and 18 CPD. Without glare and with glare did not worsen. So one was not worse or one was not better than the other at all different cycle speeds. There is now early literature coming up showing encouraging outcomes of this particular IOL in eyes with subtle macular pathology. And therefore our study adds this part to the literature, because we have strictly followed the AREDS criteria both from the OCT as well as the clinical fundus picture point of view. So the conclusion is that the non-diffractive extended range of vision IOL, the Acris of Vivity, had very good distance visual acuity along with good intermediate and near visual acuity, but the most important part, without compromising contrast sensitivity. So the clinical implications can be that it can be selectively considered in eyes with stable dry ARMD. Visual potential in such eyes may always be suboptimal due to the disease per se. However, the IOL per se doesn't cause further deterioration of the visual acuity or the contrast sensitivity. So we can probably stretch the indications of using these technology IOLs to early ARMD cases as well. Thank you so much.
I just want to clarify, what was the need for the torics? Was that the astigmatism was significant?
Yes, astigmatism.
How much was that?
So, sir, we calculate all eyes on the Barrett's toric calculator, and any eye which shows a calculation where the Barrett toric suggests an T2 or above, we consider it for toric calculation.
Was it a confounding factor, astigmatism being present and that one?
No, sir, because it was, yeah.
Dr. Sale, did you have a financial disclosure?
Yes, sir, I did. I did mention the first that it's a study is partly funded by Alcon.
Okay,
yes.
That's why you have written
yes,
ABT
yes,
IOL.
yes,
Now, how do you justify this enhanced monofocal having an edge over the usual monofocal? routine monofocal
Yes, sir. So
on the context of macular degeneration?
Yes, sir. So there are two aspects that we want to look at. One is, the clinical outcomes suggest that the the extended depth of focus IOLs give a longer range of vision compared to the monofocals. The hesitation that we have is that any, particularly with the trifocals, multifocals, retinal conditions are a big no-no. So therefore, with extended depth of focus IOLs being relatively new, there is less literature on whether they can be used in ocular comorbidities, and therefore the aim was to see that are they safe. First of all, are they making the patients worse, which they are not. And we found that the near ad as well as the intermediate ad is comparable to what is reported in literature for normal healthy macular eyes.
Did you have a control group of with an normal monofocal lens in those particular grades of macular degeneration?
No, sir. This was not.
Okay.
Thanks.
Did you give a relevance to pupillary size in these cases?
Yes.
Sir, it was not looked at in this study, but yes, there are certain studies which are looking at finding an appropriate pupil size, whether too small or too large may be appropriate for EDOF or not, but in this study we didn't look at this.
You have mentioned mesopic.
Yeah, so that is the mesopic pupil size. We measured the contrast sensitivity, but we didn't choose or exclude patients based on the size of their pupil.
Is there any difference in the magnitude of the myopia amongst this? What range they were in?
So, sir, the axial length was 23.17 plus or minus 1. 1.
So they were all matched.
All in the They were not. None of them were high myopes or high hypermetropes, sir.
Okay.
Thank you, sir.
Thank you, sir.
Thank you. Now we call upon Dr. Vijaya Vashi Dhanashekaran to tell about on long-term outcomes of SF IOL versus retropupillary fixated iris claw IOL implantation.
Good evening. Even in this era of refractive IOL surgeries, the ideal option to address challenging scenarios still remain unanswered. I am here to share the long-term outcomes of SF IOL versus retropupillary fixated iris claw IOL intraocular lens implantation. Sutureless SF IOL and iris claw IOL remain popular choices for the management of aphakia. There are several studies advocating in favor of each of these options, but there are very few reports in literature with long-term follow-up. The aim of the study was to analyze the long-term outcomes in terms of visual acuity and postoperative complication resurgery rate between scleral fixated intraocular lens and retropupillary fixated iris claw IOL. The study model was a retrospective single-center study, and patients who had a minimum postoperative follow-up period of 2 years were included. Eyes with subluxated or dislocated cataract, phakic lenses, and dislocated IOLs or post-surgical aphakia were included. And eyes with prior scleroconval tear were excluded from the study. For iris claw IOL, a scleral corneal tunnel was made following a thorough anterior vitrectomy. The iris claw IOL was initially placed in the anterior chamber. Then through two paracentesis fashioned 180 degrees apart, the haptics were then clawed using a spatula. Surgical PI was done for all the cases. For SF IOL, 1.5 to 2 mm two scleral incisions were fashioned 180 degrees apart, and a partial thickness scleral dissection were carried out in opposite direction. Sclerotomy was done through the center of this scleral incision. The haptic of the standard PMMA lens was grasped, and it was inserted through a 24 gauge needle, passed through the sclerotomy port and externalized. The same was repeated for the other haptic, and after ensuring adequate IOL centration, these haptics were tucked into the scleral pockets and the flaps were then closed with an absorbable suture. The IC IOL group had 54 eyes, whereas SFIOL had 41 eyes with a mean follow-up period of 28 months. 68% of the ICIOL group underwent primary implantation, whereas in SFIOL there is almost an equal distribution between primary, secondary, and IOLs that required decentered and eyes with dislocated IOLs. SFIOL as a primary choice was reserved predominantly for planned surgical procedure. This is a list of the ocular comorbidities. When we see the uncorrected visual acuity changes, at 1 month follow-up, SFIOL had a better UCVA, whereas at final follow-up visit, ICIOL performed better. On seeing the BCVA change over time, we can see that visual recovery in the ICIOL group occurs as early as 1 month follow-up, whereas in SFIOL, the visual recovery is seen at 3 months follow-up. Here when we see the preoperative BCVA of SFIOL group was significantly better than the ICIOL, whereas at all postoperative follow-up visit, iris claw IOL performed better. On analyzing the primary versus secondary procedure, at final follow-up, primary iris claw IOL had a better BCVA compared to secondary procedure. There was no significant change between an IOP between the two SFIL group, iris claw and SFIL group. On seeing the complication, 20% of the eyes and iris claw IOL group had CME, which was the most common complication encountered, whereas 24.3% of cases of SFIL had either lens tilt or decentration, and this was the most common complication noted in the SFIL group. 4 eyes in iris claw IOL required intervention for CME, and 5 eyes with significant decentration in SFIL were advised resurgery, and the mean time of noting decentration was 9.6 months. In our series, following an intraoperative complication, ICIOL was the predominant IOL of choice. Both these techniques had a better postoperative BCVA, but iris claw IOL performed better. In eyes with iris claw IOL, primary implantation had a significant better BCVA at final follow-up visit. All the eyes in ISFIL which had high IOP were medically managed, whereas 2 eyes in iris claw group required YAG-PA and 1 eye required cyclodiode procedure. Rashad et al. And our study note that CME was the most common complication. Decentered and tilted IOL has been reported in multiple studies in sutureless SFIL technique. And though this is a retrospective study, the longer follow-up with the good sample size add to the strength of the study. To conclude, both the IOL options provide significant visual recovery, hence they are effective procedure. Majority of the postoperative complications were amenable to medical management, hence it is a safe procedure. Primary iris claw IOL can be considered to avoid the need of a second surgery. SF IOL can be considered in cases of iris atrophy. Targeted haptic design specific for scleral pockets would counter chances of late decentration. Further prospective RCTs with the single surgeon analyzing abrometry will shed better light regarding these two options. Thank you.
Was there any OCT done previous to in these groups?
Preoperative OCT was not done, so it was a retrospective study.
Yeah, assuming that some VMT or something pre-existing, will it not confound the results? Meaning to say more of CMEs in iris claw and
group, yes, sir. So preoperative OCTs were not done, so only postoperative period the OCTs were done, sir. And when we see like there was the SFIL group had more of pre-existing retinal pathology compared to the iris claw IOL group, sir.
Actually, when you take two groups, they should be identically similar. Yes. If one group has got pre-existing, as he has rightly pointed out, pre-existing macular pathology, then CME postoperatively doesn't mean anything.
Yes, sir. And the CME was more in common in iris claw group, whereas the retinal comorbidities are more common in SFL group. One case in iris claw had a pre-existing retinal pathology, sir.
Which visco you use in for iris claw lenses?
Pardon
Which viscoelastic? Which viscoelastic you use for iris claw lens?
We use this. We use a dispersive OVD, sir, for our for the all the places of these things. The use of.
And now we have got a iris claw with 4-point fixation, which is going to be placed in an anterior chamber instead of doing retrofixation. They are more stable, I think. Probably they can also come and give a better results than what we have now. So 4-point fixation will be to prevent iridodonosis and everything. So that's much more safer, and you have to see directly. Yes, it's a little blind procedure you are putting in behind the iris and doing it,
yes,
but that should be exactly on the LTHS.
The de-enclavations noted in the iris claw were noted in the immediate post-op. The 2 eyes had in first POD and 1 eye had it in the first month, whereas SFL were more of late decentration, sir.
Yeah. And did you do iridectomy in these cases?
All patients of iris claw had a iridectomy that were done, sir.
Right. Thank you.
Thank you, sir.
We call upon the next speaker, Dr. Jabit Brayon, to speak on sitting phacoemulsification of cataract and intraocular lens implantation. Before he starts, we would be also following with the semi-final session. So those of them who have been qualified in the cataract session 1, 2 and 3, Either you call the people or you be present here. So we'll be just following it up. We just have the name list also in case Dr. Deepak Megor in cataract session 1, Dr. Debasis Datta in cataract session 2, Dr. Akash Jain in cataract session 3. Are all of you there? All the other 3? Yeah. All the 3? Yeah, fine.
Session 4 will be announced after this.
After this. And also a final call for the one which is not turned up. Is Dr. Hemant not there? He's not there. Okay. Carry on.
Good evening. The journey of cataract surgery, commencing from the ancient method of couching. Sorry, the slide is not moving. The journey of cataract surgery, commencing from the ancient method of couching, has seen colossal metamorphosis heading to the present day femto-laser assisted cataract surgery. Despite the constant revolutionizing innovations in this field, phacoemulsification introduced in 1967 by Dr. Charles Kelvin has stood the test of time and prevails as a proud torchbearer for the current day cataract surgery in delivering near pristine outcomes. Traditionally, these surgeries were carried out with the patient lying down and the surgeon operating through an overhead microscope. But what if we encounter these curveballs that hampers the ideal position for surgery? Literature exploration shelled out the following face-to-face approaches to tackle the situation, that is phacoemulsification done using slit lamp, phacoemulsification done in a semi-recumbent position, and phacoemulsification done in a motorized wheelchair. But the catch here, we operate in a secondary eye care facility that caters predominantly rural India, thus depriving us the luxury of sophisticated recliners or a wheelchair. The contemplating under the apple tree, we hit our eureka moment with the phaco sit, a novel, innovative 90-degree sitting phacoemulsification technique that precludes the requirement of sophisticated recliners or techniques. With that, the patient is made to sit comfortably in a wheelchair or a waiting chair, and the head rested on the drape pasted to the walls of the OR. The microscope is rotated at an angle of 70 to 80 degree from the vertical plane. A routine phacoemulsification is carried out with the direct chop technique, the clear corneal incision at 4 o'clock and a paracinder at 7 o'clock. No adjustment with respect to the phaco parameters, the bottle height was required. A coaxial IA was done and a foldable IOL was placed inside the bag. Throughout the course of surgery, the patient's vitals were monitored with sphygmomanometer and pulse oximeter. Presenting you a study, special study, that is sitting phacoemulsification of cataract and intraocular lens implantation. The aim of the study is to assess the outcome and determine the efficacy of phacoemulsification in sitting position. It is a prospective study carried out over a period of 6 months in a secondary eye care center in a subset of population who couldn't lie down due to supine position. Following a thorough history and assessment of both the ocular and systemic status, the eligible candidates were identified for the phaco sit technique after proper informed consent. 50% of the patients were denied surgery at 2 other institutions because of the inability to lie down flat. 27 eyes of the selected candidates are operated with phaco sit technique. The following flowchart outlines the measures undertaken at various steps of the study. Coming to the results, 27 eyes of that 15 males and 12 females were included in the study, and the majority of the eyes were left eye, and the mean age was 58 years. Coming to the results of systemic status, all through the course of surgery, the patient maintained a stable vital status. And coming to the results of visual outcome, we can see, compared with the preoperative visual acuity, there has been a significant improvement in the uncorrected visual acuity and the best corrected visual acuity from postoperative day 1 that has been maintained till postoperative day 90. 88% of the patient has the best corrected visual acuity of 6/6 at the final post-op visit. The time duration of the mean time is 10.37 minutes, and the mean average CD was 12.22. The average surgical duration of the left eye was less compared to that of the right eye, and the right eye surgery has a high CD values. There were nil intraoperative and postoperative complications. The 25 eyes included in this study, despite we operated on different gates of cataract. The verbal testimonial of patients operated with this technique skewed towards positive response with respect to the level of comfort. The surgeon has to operate with the outstretched hand without elbow support, so that prolonged surgical duration will be taxing. Right hand surgeon being a right hand operating on a right hand, there will be a hindrance because of the nasal bridge for the ease of the mobility. The phacocyt is a crucial tool for the patient who are not an ideal candidate for conventional phacoemulsification. What makes it special, distinctive and exceptional is that it can be adapted by any experienced surgeon operating anywhere without the need of additional resources. Thank you.
Was there any, other than the stretched out hand, was there any other differences noted in a phacocyt as compared to a routine phaco?
So only the positioning for the surgeon to be, we have to operate the outstretched hand, so that the surgeon is taking a long time, it will be like a little difficult. Otherwise, we didn't find any difficulty in operating this.
Meaning to say the patient is sitting, is there any more of outflow of this fluidics and any fluidic changes?
No, sir, we haven't done any. Regarding the parameters, I haven't made any change. And even at the flow, like, it's a self-sealing wound, like, and
these are all temporal tunnels?
No, sir. In the left eye, we have to put the main incision at the inferior temporal side, and in the right eye, we'll put the incision at the inferior nasal side.
In the inferior nasal, in the?
Inferior nasal in the right eye, when you're operating on the right eye.
Inferior nasal.
Inferior nasal, the nasal bridge is affected, right?
Yes, sir, but it will there will be a mild hindrance compared to, even in the study I have mentioned that the right eye surgery took little more time than compared to that of the left eye.
See, most of the cases of kyphosis can be managed if you put a stool or something there. It's not required to make it sit up, like make a sit position like this. So even the severe most kyphosis can be managed easily. Only thing you have to put a proper pillow, and you can use a stool even, just to raise your legs and do.
Yes, sir. But there were patients even with has respiratory problems who are not able to lie down there, and the patients mainly with this. I have recently saw one patient did one patient surgery with the Meniere's disease. So he has been denied. He's not taken up for surgery in different places, and she's not getting up from the bed when he is about to lie down and put the drape.
And this phacocyt is being presented, I think, for the last 3-4 conferences.
No, sir. Last 2 conferences I applied for it, but last year and last 2 years I couldn't come and present.
Somebody else had presented.
No, sir. No, sir.
I'll just. We have seen the videos. Yes.
Sir, that is there's a surgical technique of phacocyt I have presented, sir. This study this study was concluded as a special study. The series of 27 patients. This is a study was present. I'm presenting this for the first time.
Okay. Thank you.
Thank you, sir.
And we also call the people on the cataract session 4 to be here. We will be shortly announcing the winner of the cataract session 4 after some time.
Meanwhile, Dr. Satyajit, you can join us.
Yes. We also would, he is only left. He is the only one.
Satyajit.
Dr. Nichlani. Who else do we call, sir? Who else do we call? That's all.
Who will do the tabulation? सत्यजीत कैसे हो?
ठीक है सर.
Arun sir will be announced.
So the winner of this session is Dr. Shail Wasavda. So Dr. Shail will be competing for the next final session. Congratulations.
Congrats, Dr. Shail. Can we call upon Dr. Shail and with the other three to come and sit in the front row to give their presentation?
Dr. Bharti Megur. Dr. Devashish Tata. So we are going to start the next session. That's the final for free paper cataract. Dr. Bharti Megur. Dr. Deepak, you will be presenting author? Oh, sorry. Dr. Deepak is the presenting author. Yeah, please.
Dr. Deepak will be presenting on intraocular hard eye during phacoemulsification and analysis.
Respected Chair, I'll be sharing my experience with the intraoperative hard eye during phacoemulsification. As we all know, it's quite a stressful condition to be in situation like this. I think it's not moving. Can you play it?
Can you play it and also reset the timer?
Reset the timing, please. Okay. Intraoperative hard eye is a condition where it's quite stressful. As we all know, that it's basically a progressive shallowing of the anterior chamber with there's no space, iris coming out, and it can have some disastrous outcomes. So our aim of the study was to analyze the etiologies, management strategies, and outcomes after such an episode. It was the observation case series in 4,500 consecutive phacoemulsifications, and we studied the intraoperative features, what stage of the surgery did the sign appear, and the outcomes. Etiology was divided into two features, internal cause or the external cause, internal being the most serious one, fluid misdirection and suprachoroidal hemorrhage. The diagnostic measures where we deferred the surgery, indirect ophthalmoscopy in the OR or IPD or B scan to rule out. Therapeutically, IV mannitol in the OR, IV mannitol in the IPD, deferring the surgery. In some cases, pars plana tap to decompress the vitreous when aqueous misdirection was suspected. 32 eyes had the features, and fluid misdirection was the most common cause, but 2 eyes of suprachoroidal hemorrhage were seen in our series over a period of time. And in 18 eyes of the fluid misdirection eye, we had to just wait for a few minutes and the eye would soften and proceed. 2 eyes received IV mannitol at the table itself. 2 eyes we had to defer the surgery for a few hours, analyze and then go back. And 2 eyes where we did a pars plana tap at the primary setting itself, and we could continue the surgery. Just take you through few case scenarios. Eye is soft before the surgery. After dye injection and OVD, the eye becomes hard. So immediately after the fluid into the, so this is a case where I did a pars plana tap, and you could see the blue trypan, blue stained fluid coming out, and the eyes softened, and we could proceed with the surgery in these eyes. Second variant of this presentation would be eye becomes hard after the nucleus management, and there's absolutely no space for me to proceed. I just stopped for the surgery, give IV mannitol, and after that wait for 5-15 minutes in the OR itself. The eye softened, and then the intraocular lens could be managed to be placed into the eye, and the outcomes were good. 2 eyes had PCR secondary to this positive pressure because of a fluid misdirection. Pseudo exfoliation was the most common cause. Presence of dye in the burger space and these tiny lens dust particles were evidence of fluid misdirection. Visual outcome were good. 2 eyes with suprachoroidal hemorrhage. The diagnosis were extremely challenging in these. In fact, 1 eye we could miss. Conservative management, at the end of 6 weeks, we could have a satisfactory visual outcome. I'll take you through this case here. It looks perfectly well, but just before eye implantation, the eye becomes hard, and the PC is just, look at the viscoelastic, is just gushing out of the eye. The red glow is absolutely perfect. There's no problem with the red glow itself, but still, the eye is so hard, I just can't proceed further. This is what's done. We did a B scan. The axial B scan did not reveal anything. So I thought it's a fluid misdirection. And after IV mannitol, situation marginally improved. But once the lens was put, again the
pressure was relentless. I couldn't proceed. Now, since the B scan was normal, I thought I'll do a pars plana tap, and nothing came out. It was a dry, and that was a wake-up call for me. So that was then realized. I just closed up all the incisions with the lens being slightly off-center. I sutured the wounds, and then we took back again, and the central scans were normal, but the peripheral scan showed this choroidal hemorrhages, which are not visible in central scan. And just with conservative management over a period of 1 month, it just recovered with a slightly off-centered lens, but it was fine. Another case, a lady of 75-year-old, after the lens is placed, the eye becomes so tight, I can't do anything in this. 4 hours post-op, the AC is still flat, and we do a scan, and near the B scan, when we search in the peripheral area, we can find these small peripheral mounts of choroidal excavation suggesting choroidal hemorrhage. So it's very easy to miss these finding when you do just a central A scans. To conclude, intraoperative hard eye syndrome had an incidence of 0.77%. Although fluid misdirection is more common, it's not uncommon to find limited suprachoroidal hemorrhage. It is not rare even in phacoemulsification. It's just a time. I thought it's apna time. I never thought I could experience anything like this, but it what taught me. Intraoperative differentiation between fluid misdirection and suprachoroidal hemorrhage was very difficult. Presence of a good fundal glow does not rule out suprachoroidal hemorrhage. And it's very easy to miss limited suprachoroidal hemorrhage even on B scans if only the central A scans are taken. So our recommendation is, when you are in a situation like this, conservative approach would be the best thing. Defer the surgery, evaluate the case in detail, B scan, IDO, and then consider when the surgery is being deemed fit. Although more glamorous and adventurous, heroic it may sound, we would hesitate to do a pars plana tap in such difficult situations, and definitely not a limited anterior vitrectomy, which could be disastrous. So that's what the message which I would like to convey, which I learned from this. I would not poke a needle into this eye. It's just a matter of buying some time so that we can live for another day and fight the war. Thank you so much.
Dr. Deepak, they were all topical phacos.
Yes, sir.
They were all topical.
Yeah.
Was there
in
any
4,500 cases, around 350 cases we had given subtenous anesthesia intraoperatively because the patient was uncomfortable. These 2 cases of suprachoroidal hemorrhages were topical surgery.
They were topical, and was there any predisposing factor?
None of them. No systemic predisposing factor. One patient, a surprising finding was, before the surgery, blood pressure was 140/90. During the episode of this part, 3-4 hours, her blood pressure shot up. She was not she was just on one antihypertensive drug, and during this process of 3 hours when we deferred the surgery, we kept recording the blood pressure. Her blood pressure shot up to 200 to 120 at this stage, and again in next 2 days again came down. And the second patient did not have any hypertension. She was 70, not very elderly as well. And she was not a glaucoma patient. Both the patients were not glaucoma patients.
The grades of cataract and the duration
were
is comparable.
Average cataracts, there was no other predisposing factor, like typical grade 3 nucleus.
Which quadrant did you choose for that suprachoroidal tap?
This was not a suprachoroidal tap, sir. It was just a pars plana tap for this
Which
thing.
quadrant?
It was in superiotemporal quadrant.
Superiotemporal.
Yes, sir.
Okay.
I was sitting in the temporal. All these incisions were being temporal. I just chose the behind it, superiotemporal.
So you have said you were doing a tap, and you said anterior vitrectomy would be disastrous.
Yes.
What about limited posterior vitrectomy?
No, I think anything entering into the eye now, yes, sir. No,
on core vitrectomy.
It is going to be much more disastrous because that will be uncontrolled. Like, even tap is a little bit permissible even because it is just a valvular and just closes on it. Because basically you want to close the eye as is muscle. When you open and evacuate and start creating hypotony, the choroidal vessels rupture, and which could have been a limited suprachoroidal hemorrhage, it just expands. Now the outcomes in this series were very good because we just closed immediately, and the hemorrhage was in a localized area. If you continue with the surgery, it's going to expand, and if you still don't realize, it could end up in an expulsive hemorrhage as well.
When you have evaluated these cases with the ultrasound, which quadrant did you find having most suprachoroidal?
So they'd never present in the central axial zones.
Yes.
So what we found was in the first case, it was in the inferotemporal quadrant in the first case, and in the second case, it in the far end in the superionasal quadrant. So it was not very definitive. They are so rare.
By book, it should be inferotemporal and inferonasal, commonest ones.
Yes, sir. Yes, sir.
Thank you so much. It was an excellent presentation.
Thank you, Dr. Deepak. Now we call upon the next speaker, presenting speaker, Dr. Debasis Datta, to speak on negative dysphotopsia, an enigma of the past.
Good afternoon, respected judges and dear colleagues. So, negative dysphotopsia, an enigma of the past. Negative dysphotopsia is a burning question. It is ubiquitous with uncomplicated in-the-back phacoemulsification with any type of lens that we use. In the immediate postoperative period, the incidence is as high as 12 to 45%, and even more is reported in the literature. It comes down thereafter. So, given the burden of a cataract surgery's journey in India, should I go on?
Please start again when the timer starts.
Okay, should I go back? Okay.
Please start the timer.
Just start the timer and
yes,
you will
yes,
also start
it has been
presenting.
started.
So can you just go
from
back
the
to
beginning?
slide?
Yeah, from the beginning.
I cannot go back here.
Okay, okay, you start from this point.
Yeah.
So with the burden of number of surgeries that is done in India per year, about 15% of what the phaco is done. So about 8.34 lakhs of patients suffer from negative dysphotopsia in the immediate postoperative period, though it comes down to 2.2% after a lot of time. Excuse me, the slide is not moving. Can I have the right from the beginning?
Please come and help. Can you please come and help?
Can I have from the it's now
slide
moving.
is not moving.
Management of strategies have come into place. So there are yak cap, piggyback IOLs, laser truncation of the IOL, whatever, there are lots many. But the most popular are reverse optic capture, primary or secondary, and back to sulcus IOL exchange. So aim of the study is to find the incidence of negative dysphotopsia if we place the IOL in a particular manner. Let's see how. In case of sulcus placement, the effective lens position and centration are at stake. They're not very well defined. If you do a reverse optic capture, there is iris chaffing, release of pigments, and the sequelae. So, to have the best of both worlds, I place the haptics in the sulcus, and the optic is captured inside the rhexis margin, inside the back. So, it's a descriptive, observational, non-randomized, consecutive retrospective study done between April to December 2023, where a particular band of hydrophobic acrylic multipiece lens is placed in the sulcus, and the optic was aptly captured inside the bag of 5.5 millimeter rhexis. A double masking is done, whereby a telecaller would call up the patient on the second postoperative day before the patient reports for first follow-up to the doctor. So there is no bias, and the telecaller inquires about the black shadow and notes it down. So here suggests the way how it is done. A multipiece lens is first haptic goes into the sulcus in front of the optic, in front of the rhexis. The second haptic also goes into the sulcus. Thereafter, the optic is nudged so that the optic edges are below the rhexis margin. So you nudge, so the square edge of the optic does not cause iris chaffing. In the immediate postoperative period, you can see the haptic is out of the bag in the sulcus, and the optic is covered by the rhexis. This is how it looks. So the results, 223 patients were taken up, of which the negative dysphotopsia was noted in the immediate postoperative period as 3.5% vis-a-vis 15 to 45% in the immediate postoperative period as reported in the literature. So what does this study add? The reduction of negative dysphotopsia through strategic placement of IOL is possible. Furthermore, innovations in various types of IOL design and surgical practice can be done based on this. So we have ignored it for a long time, saying that it will go away on its own. Wait for some time. But with this premium IOLs coming into play, when somebody walks in the first post-operative visit and says that I'm having this negative dysphotopsia, black shadow, do something for me, why is it there? So we must give it a thought. It is time for us to give it a thought for all types of IOL. So this may predict us to design the IOL optics and haptics in a new way, whereby we can place the haptics in the sulcus, and bring the plane of the optic a little bit in front.
They were all square optic ones. Three piece.
All three-piece lenses, because I could have done it with single-piece lenses, but that would have raised eyebrows. But first, let us do it safely.
And the capsular axis was optimized. They were all comparable.
Yes, all. I marked it on the, some were done on this thing, and I marked it with a marker on the cornea. 7.2 millimeters on the cornea will give me 5 millimeters on the rexis.
So what was the incidence of PCO in these cases? Because
PCO,
you see,
it is a follow-up is about 6 months, highest follow-up. There's not much of PCO, but PCO can happen. But
because this is lying little anterior, what should be there on the.
Sir, the purpose of
so
this
it should
study,
not providing barrier to the PCO formation.
I understand, but the purpose of this study is negative dysphotopsia is the main point. I understand. It is, if we are taking it off the PC, the incidence of PC
And
might be more.
how common you find the NDs negative dysphotopsia is common? How common is it?
In which? In normal
in normal cases, yes.
Pretty high. And the literature puts it at 15 to 67%.
Yeah.
Depending on, and one more thing, where you solicit the question, you ask the patient, are you seeing the black shadow? Some more patients will say, yes, I'm seeing it. But whatever this 3.5% I have shown, we solicited the, of our own, we put up a leading question that, are you seeing this black shadow? After that, it has come 3.5%. So that's how it is. But if you don't ask, it will be even less.
So there are many ways to deal with these things. One is, as you shown it, there are other methods also to deal with this condition.
Piggyback lenses, truncation, capsulotomy.
Even capsulotomy helps a lot.
Bring it out of the bag, reverse optic capture. But the reverse optic capture below the iris moves and the pigments are released.
Right.
So they can be done as a scapegoat situation, but should not better be avoided.
And these the haptic orientation, how are they oriented? The haptics.
The study which was done with inferotemporal position of the single piece IOL's haptic study, but this being a multiple study, it is irrespective of as because it's a very thin haptics, so the position of the haptics
doesn't
have any bearing on the negative dysphotopsia and the positioning of the IOL. And one more thing, as because it is captured by the rexis, the plane is defined. If you place it in the sulcus, it is somewhat undefined and the centration may be at stake. But if it is captured snugly by the rexis, the plane is defined, and also the centration is also profoundly defined.
I think negative dysphotopsia is more common in surgery, which was done perfectly well centered, very clean,
Absolutely.
Thing. And most of the patient over the time, they just ignore it. The reason being, one is they ignore it. Second is the fibrosis which occurs on the capsular margin. That also take care of this.
It is in the immediate post-operative period. It's a lingering question. That is what we are bothered about.
Right. Thank you.
Thank you so much.
Shall we call the next? Yeah. We move on to the next speaker, Dr. Akash Jain, to speak on evaluating contact of IOL with PC with respect to haptic orientation and CTR implantation using AIOCT.
Good afternoon, everyone. So, toric IOLs have changed the way we address astigmatism in pre-cataract patients. There's only one problem. They tend to rotate, and the maximum rotation that has been seen is within 1 hour post-surgery. So, that brings us to our research question. Can we reduce the early toric IOL rotation? So, here is an intra-op OCT scan, where the first line that you see is the anterior face of IOL, the second line is a posterior face of the IOL, and the third line is a posterior capsule. What we intend to achieve is a better IOL contact with the posterior capsule, which should look something like this. So how do we achieve this? For this, we had 2 arms of this study. First, we tried to orient the haptic. We checked whether orientation of the haptic has any role in achieving a better contact. So we implanted the haptics we implanted the lens in a horizontal and a vertical position of the haptics. So with that aim, we studied 100 eyes in a prospective interventional study. These patients were selected with normal biometry and a non-complicated cataract patients. After the preoperative evaluation, during a clear corneal topical phacoemulsification surgery was done, once the lens was implanted, it was first placed horizontally. Intraoperative OCT scan was taken, something like this. After lens implantation, we aligned the lens horizontally with the haptics horizontally, and an intraoperative scan was captured. A screenshot was taken of the scan. Then the lens was rotated to have the haptics align more vertically, and the scan was captured again. That's the vertical orientation. So if we compare these two scans over here of the vertical and the horizontal orientation, you would notice that when the haptics were aligned vertically, the contact was much better. So we measured this distance of intraoperative OCT in terms of pixel density, and the difference was around 20 pixel density in both scans, the horizontal scan and the vertical scan of the intraoperative OCT. The second arm of the study was where we implanted a CTR in these eyes and checked whether this implantation was any better. With that aim, we studied 100 sample size of 100, and a random selection of CTR size was taken of 11, 12, and 13. So the patient eyes, the inclusion exclusion criteria was similar to the previous arm. After the preoperative evaluation during surgery, the lens was implanted first. Intraoperative scan was taken. A CTR was implanted after that. When we implanted the CTR, we have to make sure that it does not entangle with the haptics of the IOL. So that one slight adjustment is what you see right now in this video. And the scan was taken again after the CTR implantation. On comparing these two scans, you would notice that the contact has improved after a CTR implantation. So what happens is the CTR stretches the back to increase contact between the posterior capsule and the IOL. And when we compare the results, maximum contact was achieved by 13 mm CTR size, but the contact was better with 11 mm as well. Yeah, so this is the first study which checks the placement of CTR and IOL orientation in the same eye. This was done using a real-time intraop OCT, and all surgeries and the scans were captured under physiological IOP of 20 mm Hg. If you notice, the irrigation cannula is kept inside the eye with the IOP set to 20 mm Hg to have a more comparable outcome between the two eyes and the two groups. So how does this guide us further? During this study, we noticed that if you notice a sudden deepening of anterior chamber, these eyes are more susceptible, more prone to a IOL rotation. So that is something that we noticed, and any studies which talk about toric IOL stability should exclude these particular eyes as it can skew your data. Companies should, like one of the proposal is that companies should design toric IOLs which need to be placed vertically to have a better IOL contact, and try using CTR in toric patients. This will reduce this early post-operative rotation. To summarize, vertical orientation of IOL provides a better contact of IOL with the capsule, and CTR provides a better contact as well.
What was the refractive status of these patients? Were they comparable?
Yes, sir. They were comparable in terms of refractive error and biometry. So we, in both groups, in both studies, in both groups, we took patients where the biometry was comparable. The normal range of axial length, white to white, was taken, and none of the extremes of myopia or hypermetropia were included in the patient to have a more comparable.
The same lens was used.
The same lens was used in all patients.
Was there an increase in incidence of negative dysphotopsia in these cases? Once you put it, yeah.
So
because the optic haptic junction also prevents some negative photodysphotopsia.
I agree, sir, but that would be one of the limitation to the study, as sir rightly put in the previous talk, that this was something that we did not ask our patients. Maybe we should have asked, we could have had a reliable result, but there was no active complaint. We did not have a patient who came on POD 1 saying that I am having negative dysphotopsia. Maybe we could have asked.
Right. Thank you. Thank you so much.
Next presentation, we now call upon Dr. Sayal to give his talk on visual outcomes following implantation of EDOF IOL in patients with macular degeneration.
This study was funded in part by research grant support from Alcon Laboratories. The purpose of this study was to evaluate visual outcomes following implantation of a non-diffractive extended vision IOL in patients with pre-existing early dry age-related macular degeneration. It was a prospective interventional case series performed at Raghudeep Eye Hospital at Ahmedabad and Jaipur, and all patients were 40 years of age and above, undergoing phacoemulsification for non-traumatic cataracts. All eyes underwent phacoemulsification with in-the-bag implantation of a non-diffractive wavefront shaping extended vision IOL, the VVT from Alcon Laboratories. Patients with uncomplicated age-related cataracts and nuclear sclerosis ranging from grade 1 to 4 on the LOCS 3 grading system and pre-existing stable early dry age-related macular degeneration were included, and early dry AMD was defined based on the AREDS2 study criteria, which means multiple small drusen's less than 63 microns or few intermediate drusen's between 63 to 125 microns, or pigmentary changes at the macula. So they were both quantified on fundus photography by the retinal surgeon as well as on posterior segment OCT of the macular scan. All patients who had either wet macular degeneration, large drusen's, or any other retinal or ocular comorbidities were excluded from the study. The primary outcome was monoocular corrected distance visual acuity at 4 meters on the ETDRS chart. The secondary outcome measures were monoocular unaided distance visual acuity at 4 meters on the ETDRS chart, monoocular uncorrected and distance corrected intermediate visual acuity at 66 centimeters, and monoocular corrected and uncorrected distance near visual acuity at 40 centimeters. The average age was 68.5 plus or minus 8 years. There were equal number of male and females and almost equal number of right eye and left eye. And the axial length, the biometric parameters were the normal axial length patients, that is 23.37 plus or minus 1.1 millimeters. So no extremes of axial myopes or hyperopes. And the average nuclear sclerosis was 2. 63% of eyes required a toric version of the VVT, as all of the patients were calculated on the Barrett's toric calculator and all needing toric IOLs were included. Coming to the results, the uncorrected distance visual acuity in logmas was 0.12 plus or minus 0.07, which is equivalent to 6969 parts, and the corrected distance visual acuity was 0.1 plus or minus 0.1. So the mean corrected distance visual acuity in Snell's equivalent was 6 by 7.5. The uncorrected near visual acuity was 0.25, corrected intermediate visual acuity was 0.1. Similarly, the uncorrected near visual acuity at 40 centimeters was 0.23 and the corrected near visual acuity was 0.1. The average near add needed for 66 centimeters was 0.86 diopters plus or minus 0.18, and the average near add needed at 40 centimeters was 1.36 plus or minus 0.18 diopters. The most important part of the study, that is studying the contrast sensitivity with and without glare in physiological mesopic conditions, that is in a dark room at different cycle speeds 3, 6, 12 and 18. Fortunately, with glare and without glare, none of the cycle speeds showed any significant difference or worsening of the contrast sensitivity in the mesopic conditions. There is now early literature showing encouraging outcomes of these non-diffractive wavefront shaping IOLs in eyes with subtle macular pathology. The strength of our study, this being prospective and following the strict AREDS2 criteria, is one of the strengths of our study. So in conclusion, the non-diffractive extended range of vision IOL had very good distance visual acuity, along with good intermediate and near visual acuity, but most importantly without compromising the contrast sensitivity. The clinical implications can be that it can be considered in select eyes with stable early dry macular degeneration. The visual potential in such eyes may be suboptimal due to the disease itself, and therefore patient counseling preoperatively remains equally important. However, the good part is that the IOL does not seem to cause further deterioration of either the visual acuity or the contrast sensitivity. Thank you so much.
Excellent presentation. I just wanted to know what was the real aim you were trying to find out with this?
So the aim, the thing is that the extended, until now, presbyopia correcting IOLs are the multifocal and the trifocals, which are absolute no-no in any form of ocular comorbidities, including retinal pathologies. With the extended depth of IOLs coming up in the last 4-5 years, there is more and more increased interest whether they can be used in eyes with subtle macular pathologies as well. So the aim here was to see, first of all, whether this IOL is making things worse in a patient with a stable retinal pathology. So the aim was to find out whether it's doing any harm to the patient.
Because at the end of the presentation, there was one line which said the vision will still be compromised.
Yeah, because the age related, say for example, so if the visual potential is only 6/9, it will remain 6/9, or if it is 6, but it's not making the contrast or any of the other parameters worse compared to the already existing outcomes of these IOLs in normal eyes. So the average near ad required, the contrast sensitivities, everything is comparable. Yeah.
Thank you.
Thank you, sir.
Total calculator on
The presenters of the fourth, the finals, semi-final, this thing, just stay back. We are just compiling the results.
I think it's a very, very close fight. All of the four have a very nice presentation. Just we are table, maybe there may be difference of just 1 or 2 marks in between it all. We don't have to announce it. Basically, we are not supposed to announce, but the winner of this session is Dr. Vasabdu. And it's a very, very close fight.
Yeah, very close fight, and we are tallied up all the four and took an average. All the four presenters were really equally good, and congratulations to all of you. And I also want to thank the organizers for the opportunity. I also want to thank the judges, co-judges.
Actually, all of you are winners because we have won the individual session.
Okay. हो गया सर पिछले कैसे डॉक्टर साहब
all the 4 finalists can come here.
Just will have a group photograph. All the finalists. Can you just call them now in one of the just